Good morning. Welcome back to Global Neurosciences Institute Grand Rounds. Now it is my great pleasure to introduce Dr. Carla LoPinto, who is my former colleague and very respectful epileptologist. A very respected epileptologist. Dr. Carla LoPinto Khoury is an associate professor of neurology at Katz School of Medicine at Temple University. She currently is the clinical director of the Genes Neurology Division at Temple University Health System. She completed her undergraduate degree in biology at Cornell University and her medical degree at NYU School of Medicine. She completed her neurology residency and fellowship training in clinical neurophysiology and epilepsy at Thomas Jefferson University. She has published research on clinical epilepsy with an interest in long-term effects of anti-seizure medications. She has presented on epilepsy research topics in both local and international conferences. She's a fellow of the American Epilepsy Society and is serving as the chair of the Epilepsy Foundation of Eastern Pennsylvania Professional Advisory Board. Dr. LoPinto will be talking today about cardiac risk mitigation when treating epilepsy. Dr. LoPinto.
Thank you so much, Dr. Glebus, for that kind introduction. All right, thank you very much for joining us this morning. So again, like Dr. Glebus said, I will be speaking today about mitigating cardiac risk when treating epilepsy. So the fun title is Saving the Brain Without Risking the Heart. I have no relevant disclosures yet for this. None have not been receiving any payment or anything toward anything related to this talk. The learning objectives for today. I hope you will be able to define SUDEP and the concept of the epileptic heart. We'll review the effects of anti-seizure medications on cardiac risk, in particular to the risk of arrhythmias and atherosclerosis risk. And at the end, one should understand how appropriate medical and surgical therapy can mitigate cardiac risk. So the first thing I'd like to do is just review some clinical cases. There are three that I would like to have you sort of just read with me and then, think about the questions as we move through the talk. And then at the end, I'll bring them back. And then at that point, perhaps you can participate and let me know your thoughts about the questions. The first is a 41-year-old man. He has a history of epilepsy since he was 14 years old. And he has focal seizures with an epigastric aura. And they occur about 3 to 5 times per month currently. He has had generalized tonic-clonic seizures, and his last one was 1 year ago. He is currently taking levetiracetam 1,000 twice a day and carbamazepine extended release 400 twice a day. He has previously tried phenytoin, topiramate, lamotrigine, but has not achieved complete seizure remission. So the questions I want you to think about for this case would be, how would you evaluate this patient to assess his risk of SUDEP and his cardiac risk? And how would you counsel this patient about that risk? And what treatments might mitigate his risk? For case number 2, we have a 19-year-old woman. She has developmental delay and moderate intellectual disability, and she has nocturnal convulsive seizures since the age of 13. Their frequency is about 1 to 3 times per month. Her EEG showed generalized discharges, her MRI brain was normal, and she's currently taking lamotrigine 150 milligrams twice a day. So for her, how would you counsel her and her family about her SUDEP risk? What evaluations might you consider, and what therapy modifications might help her risk? The last clinical case is a 50-year-old woman. She has seizures since the age of 5, and she described them as staring spells. She was taking phenytoin and carbamazepine when you started seeing her, and she's been seizure-free for at least 20 years. She has a history of hypertension and hyperlipidemia, but she is afraid to change her medication since you're her new neurologist and her old neurologist of 20 years just retired. So this is not a fake case. How would you proceed with her monitoring, and how would you counsel her on the risks and benefits of switching or discontinuing medications? So let me go into SUDEP and the epileptic heart, which has received a lot of attention lately for good reason. We define SUDEP as the sudden, unexpected death in people with epilepsy that's independent of the evidence of a seizure, when trauma, drowning, and status epilepticus have been excluded, and a post-mortem examination, such as autopsy, does not identify a cause of death. The overall incidence of SUDEP is 1.4 patients per 1,000 patients per year. However, it depends on what population you're seeing. And so, for instance, that number ranges from 0.9 to 2.3 in the community, but for patients with treatment-resistant epilepsy, their risk is actually higher. And those who are in the pool of patients undergoing surgical evaluation have a reported risk of close to 1 in 100. So that can be very different. I want to go into the classification scheme of sudden unexplained death in epilepsy. So we have definite SUDEP, in which case the patient has had an autopsy and there is no cause of death identified. Okay, this will be an unwitnessed death, and then definite SUDEP plus would be if the patient has had an autopsy and there may be a potential other cause of death as well. If there's probable SUDEP, that's classified because there has not been an autopsy. And if there's possible SUDEP, that means that a competing cause of death is present. Then we have near SUDEP, where of course the patient survives after cardiopulmonary arrest. And then, of course, not SUDEP and unclassified due to lack of information. The risk factors for causing SUDEP. So most SUDEP is witnessed following a seizure, if it's witnessed at all. Typically it's not. But in a substantial minority of those who have been witnessed, there's not a seizure immediately prior to death. So the patients who have refractory epilepsy, those who have a history of generalized tonic-clonic seizures, and those with a developmental and epileptic encephalopathy, all of those things are risk factors for having SUDEP. And there are some genetic syndromes that are known to be associated with SUDEP at a higher risk. So for instance, Dravet syndrome has an almost 15% chance of risk of SUDEP. Some of these sodium channel gene mutations, there's a Gator complex that also has been identified to be a high risk of SUDEP. And also patients who have the chromosome 15q duplicate are at higher risk. Patients who have their seizures at night might be at higher risk. And we think so because SUDEP does have a predilection for happening during the night, during sleep. Importantly, SUDEP tends to have this peak of incidence in adolescents and young adults, which is very important to understand how traumatizing this can be to families and how much loss of potential life there is without addressing this problem. So, we think of epilepsy as just a problem in the brain, but SUDEP is associated with epilepsy, and it's clearly something that is related to the heart as well. And the brain, of course, as you know, is not in isolation from the heart. And this diagram helps us to understand the complex interaction between the brain and the heart that's pertaining to SUDEP. So, for instance, the heart will actually give some efferent information to the brain through baroreceptors and chemoreceptors in the blood vessels, and also will give some input to the brain into the nucleus tractus solitarius. And the brain, in turn, will give information to the heart via the autonomic nervous system. So through the parasympathetic outflow from the dorsal motor nucleus of the vagus, through sympathetic outflow through the stellate ganglia. And there will be some endocrine effects that come from the brain through the hypothalamus into the adrenal gland. And these effects will in turn affect the heart's heart rate, contractility, conduction, repolarization, and the patient's blood pressure. This is a kind of conceptual framework. I like this way to kind of think about the epileptic heart, which is a term that was coined by this team, Verrier et al. So these patients who have chronic epilepsy, although one seizure will not necessarily cause death, there may be repeated hypoxemia and myocardial ischemia, if the patients, have respiratory depression during and after a seizure. And then after a seizure and during a seizure, you have this big catecholamine excess, including adenosine, which I'll mention in a bit. In addition to that, the patients who are on anti-seizure medications that can affect their cardiac risk will have had long-term problems leading to a position of the heart being at risk for sudden death. So, during a seizure, you can have myocardial stunning over and over. This, will lead to changes in the heart myocytes over time, including, increased vacuoles, interstitial fibrosis, which has been seen in autopsies of patients with epilepsy that's not well treated, and then accelerated atherosclerosis, which is, as I'll just show you, is going to be affected by long-term risk of seizure drugs. This all leads to electrical instability of the heart. And so T-wave alternans, atrial and ventricular arrhythmias can lead to a ventricular tachycardia and fibrillation and sudden cardiac death. And so that's this sort of proposed model for how the epileptic heart will lead to SUDEP. So how do we prevent SUDEP, right? So right now, the best treatment plan is to treat the seizures, okay? But, there's things that you can do as a provider that, can improve the patient's compliance with the plan to treat their seizure. And the clinical guidelines all recommend counseling the patient at the time of diagnosis, especially for populations at increased risk. Repeated counseling is also recommended. So, it is a little controversial that, many physicians actually feel like counseling the patient may cause undue anxiety and stress, because there's a thought that we really can't do that much to prevent SUDEP. But I believe that we should be counseling patients more and making this some part of our practice in a thoughtful way. There are some prevention strategies that are specific. For instance, with Dravet syndrome, fenfluramine has been shown to help prevent SUDEP. For children, it's thought that SSRIs might actually be helpful because they might stimulate the brainstem respiratory centers. And like I said, there's this big catecholamine excess after a seizure, and that includes adenosine. So blocking the adenosine receptor could be a way for us to prevent SUDEP, especially in high-risk populations. And it's interesting because the body makes adenosine. It's this endogenous anticonvulsant. And so at the time, it helps stop the seizure, but over time, it may cause problems with the heart. Another thing that is, not standard of care, but is sort of emerging, is considering diaphragmatic pacing for high-risk patients to prevent post-ictal hypoxia. So now I'd like to go into the potential effects of anti-seizure medications on cardiac arrhythmias. So the medications I'll be talking about are going to be sodium channel affecting agents. So the first one is phenytoin. And it's interesting because phenytoin is considered a class 1B antiarrhythmic, and it has been used for treatment of digoxin toxicity and atrial fibrillation. But when it's infused rapidly, it can have the side effect of hypotension and bradycardia, even asystole. Of course, that's a big problem. So, why is that? Is it just the sodium channel blockade? Well, partly. It does seem that because phenytoin is soluble not in water, but in propylene glycol, that solute actually is the main culprit of this side effect. However, when we use the water-soluble form or phosphenotoin, that actually can cause hypotension and arrhythmias as well when infused. So there is some direct effect of the drug. So it's not terribly well established in terms of guidelines for the safety of IV phenytoin, although we do feel confident that the oral form is safe for the risk of arrhythmias. But when we're giving it for patients with status epilepticus, we really have to be mindful of the infusion rates. So you want to be able to stop patients who are having status epilepticus, but if you try to stop it too quickly, then you might have real problems. So for patients who are older, what does that mean? Is it older than 50 or 60? That's not clear. And for patients who have a history of bradycardia or other arrhythmias, it's recommended to use a rate of 25 milligrams per minute or less. And for the general population, you target 50 or less. Whether or not you need telemetry monitoring, special ICU monitoring during infusion is also considered controversial. And while that's the ideal, for instance, I just had a case of my own in which a patient was on an unmonitored floor, and they were actually a patient, who was DNR and would not be going to the ICU. However, the nursing protocol stated they could not give phenytoin on the floor. And so that proved to be a problem because treating status epilepticus is actually palliative care. So it's something to keep in mind. Lacosamide, it works a little differently than most of the standard sodium channel blockers in that it affects the slow gated, not the gated sodium channels. So you can see this sort of little gate, and this is how your classical anticonvulsants work. It just sort of, takes this little gate and it closes the gate. However, lacosamide works on changing the configuration of the sodium channel, and that's a slower process. We do see that lacosamide can affect the PR interval and lead to bradycardia. So in my practice, I do check EKGs for patients who are above the age of 50 or any patient with potential cardiac risk. And then I continue to monitor that periodically to assess for any changes. So this was actually something that happened fairly recently around 2020 that caused some raised eyebrows in the epilepsy community. So this is very interesting that the FDA had some in vitro data that was started in 2011 from a group that saw some potential cardiac effects of lamotrigine. And then there were post-marketing studies that were done by GlaxoSmithKline, I believe, that showed that there was a weak class 1B antiarrhythmic effect on human cardiac Purkinje cells. And these effects shorten the QT syndrome. So this is a theoretical problem in patients who have short QT syndrome, and this is a rare inheritable condition. So if you take it together with other drugs that shorten QT intervals, like other antiarrhythmic medications, it might be a particular risk. Based on this, the FDA took an unusual stance and just just mentioned avoiding use of lamotrigine when possible. And of course, between the epilepsy community and the psychiatric community, then, this was a big deal. So there was a, task force of the International League Against Epilepsy, and they made recommendations that if anybody has a cardiac history or is above the age of 60, that it's recommended to perform an EKG for those people, which, it was unusual and not something that neurologists were doing at the time. However, later on, there was a large population study just, last year, that really sort of, broke down this risk in a very large, like, countrywide study in Europe. And they showed that really the hazard ratios for any cardiac events was 1 for many different subgroups of the population, including older age, including other risk scores. So I do think that we should follow any of the recommendations about doing EKGs, but in general, we do still believe that the risk of lamotrigine is very rare. So of course, there's, always a rare exception. So this would be case reportable. There's only about a half a dozen cases in the literature of lamotrigine causing unmasking of Brugada syndrome. So this is an example of a abnormal EKG on the left showing J point elevation and ST segment elevation that improved after the cessation of lamotrigine. So again, not the most common cardiac arrhythmias. So moving on from the risk of arrhythmias, I want to speak about the risk of atherosclerosis with anti-seizure medications. And this is mainly based on the effect of anti-seizure medications on cytochrome P450 enzymes. So the inducers of cytochrome P450 enzymes, we'll abbreviate them as this EIASM, so enzyme-inducing anti-seizure medications, versus the non-enzyme-inducing anti-seizure medications. So these non-inducing anti-seizure medications include the inhibitors of valproic acid, which, as I'll go into, might be problematic for other reasons, or medications that are neutral. So here's a list, as updated as I can get, of a classification of seizure medicines that are enzyme-inducing or non-enzyme-inducing. So again, valproic acid in the non-enzyme-inducing category, but is enzyme-inhibiting. And enzyme-inducing anti-seizure medicines that are well-known include carbamazepine, which is really the very common essential medication, phenytoin, which is being used less now, of course, the older generation medications, phenobarbital, primidone. And then there's the weakly inducing anti-seizure medications, including oxcarbazepine, eslicarbazepine. These can be enzyme-inducing if they're taken in high doses. That includes rufinamide and topiramate as well. And then some medications do have some mixed effects, but can, in certain cases, be inducing to some of the enzymes. So that includes cannabidiol, cenobamate, clobazam, and perampanel. Of course, the medications that we prescribe regularly, levetiracetam, lamotrigine, zonisamide, lacosamide, and gabapentin, now brivaracetam, these are considered to not have effects on the cytochrome P450 system. So, why is this important? So if these medications cause an increase in your markers of vascular risk, this can have real consequences. So one way that we can have a marker of vascular risk is with measuring carotid intima media thickness in just a regular carotid ultrasound. So this would be how one measures that thickness. And, the concern about anti-seizure medications, which started decades ago, really started when they were actually investigating this with children. And so, having children with a thicker carotid intima could lead to potential, risk of stroke, and probably is a marker of potential cardiac atherosclerosis as well. So the reason that we believe that these enzyme-inducing medications are particularly prone to having this effect is that the entire pathway in the liver of converting acetyl-CoA into your cholesterol and other metabolites is highly regulated by the cytochrome P450 system. So we know, and my previous research that I did really established that vitamin D is lowered by carbamazepine and hence other forms of anti-seizure medicine with that property. We do have some evidence that thyroid hormones can be lowered by anti-seizure medicines. And then cholesterol is, degraded into bile acids, and both the synthesis and degradation is affected by these medications' effect on the catalyzing enzymes. There's also some indirect effects because cholesterol's metabolites also can produce estrogens, progesterone, testosterone, and cortisol. So it is a complex system. And just sort of a little more detail is that the HMG-CoA reductase is the enzyme that converts the production of acetate into cholesterol through a number of intermediates. And remember that HMG-CoA reductase is the target of your statins, your common cholesterol-lowering medications. Because this process has some feedback inhibition affecting the enzymes that catalyze the intermediates, can cause sort of a complex feedback problem and then cause a feed forward effect on the cholesterol levels. So whether or not this was clinically relevant was proven in multiple studies. This one was particularly important because this showed that when patients were switched from carbamazepine to lacosamide, the non-enzyme inducing medication, after 12 months, there was a substantial decrease in the percentage of patients with high cholesterol and high LDL. However, the patients who did not switch and continued with carbamazepine had a substantial increase in their in total cholesterol and LDL. So then one would think that you could mitigate that risk by simply adding a statin medication to lower cholesterol. However, the same group did a study on some data already available for switching to non-enzyme inducing medications. And it showed that when patients were taking statins and they were on carbamazepine, their cholesterol levels did not go down. However, if they were taking lamotrigine or levetiracetam, their cholesterol levels went down, and conversely, HDL cholesterol levels went up in the non-enzyme inducing medication groups, but not for the carbamazepine groups. So similar with the LDL fractions. So this means that just giving a statin medication is not a good strategy. Another important thing is that pretty recently, there was a very large population study in adults on data from the United Kingdom. And this was over 30,000 persons with epilepsy since 1990. And they studied the hazard ratio of risk of developing a heart attack, stroke, or angina, or TIA. So all those potential cardiac events. And they found that there's a big difference when they looked at patients who were receiving the strong enzyme inducers versus non-enzyme inducers. And here is their accumulative hazard graph. So they had a long follow-up time, of course. So this is, up to 25 years. It seems like after 10 years, you start to see a substantial change. And your risk after 20 years of taking enzyme-inducing anti-seizure medicines is double the risk of if you took non-enzyme-inducing anti-seizure medicines. To try to break down the question of why, they did a mediation analysis, and they looked at the total effect of enzyme-inducing anti-seizure medicines on the incident cardiovascular disease. And they broke it down into the direct and the indirect effect. So the indirect effect was considered incident dyslipidemia, or high cholesterol, that was diagnosed after they first started taking the enzyme-inducing meds and before they were diagnosed with cardiovascular disease. And from this analysis, we say that the effect of just having the hyperlipidemia from the drugs is only part of the answer. So, we know that these medications can raise cholesterol, but there's something else going on. So this is actually a chart that we made quite a while ago. And at that point, it was established that, we knew that total cholesterol was raised by the enzyme-inducing medicines. We seem to think that valproic acid lowered it based on some studies with children. But there were other markers of vascular risk that were sort of not well understood at that point. We thought that carbamazepine raised the lipoprotein A fraction and CRP. We had some mixed data suggesting that not all these enzyme-inducing medications behave the same way. And we really didn't have very much good data regarding valproic acid. So what are these other markers of vascular risk? So lipoprotein A is different than what you measure in your regular lipid panel, which is LDL. So lipoprotein A has this attached protein, the apolipoprotein. And so that's an independent marker of risk, and something that it seems that we are under testing for. And patients who are at increased risk patients who have higher apolipoprotein will be at greater cardiac risk, even if their cholesterol levels are not yet high. And unfortunately, the problem is that the effect of our standard therapy to lower cholesterol might actually make lipoprotein levels higher. So we don't really have a way to target lipoprotein. And that's important when thinking about the effects of anti-seizure medicines, because again, you may not be able to mitigate that risk by just treating their cholesterol. These other markers include CRP, which is the inflammatory marker, synthesized in the liver, and it does have this strong association with cardiovascular events, again, even in patients who don't seem to have high LDL. And then there's homocysteine, which is this amino acid with prothrombotic properties. And that, although we don't necessarily think of stroke and dementia to be cardiac problems, they do. It may be that homocysteine's role also is important here. And then I also want to speak about valproic acid, which is the most effective agent in juvenile myoclonic epilepsy, which is a common cause of epilepsy. And we know that it can cause obesity, especially in women. And we know that it can result in a metabolic syndrome, which can lead to glucose intolerance, elevated triglycerides, low HDL, and high blood pressure. And it's not because of its enzyme effects, because it's an inhibitor. So when they do sort of quick studies in children, they do see that cholesterol levels go down. But think about the long-term effect of valproic acid. There are so many pathways by which your lipids can actually get worse. And this is through increased appetite, carbohydrate intake. There's effects of the valproic acid on your glutamine, your oxidative stress on your pancreatic cells, adiponectin, and your free fatty acids that are circulating. All of this can lead to insulin resistance and eventually elevated lipids. So it's a complex metabolic change that occurs, and something that really has not been teased out well in the clinical literature, like the one I showed you with the large population study. So then we know that these medications, in particular the enzyme-inducing anti-seizure medications, can cause patients increased cardiac risk. So that doesn't mean we stop all seizure medicines, of course. So when should you consider, though, potentially tapering patients off a medication? So things that would give you an idea that you might be able to, or if the patients are at least 2 years seizure-free, although in my practice, I probably go for more. If they have had rapid seizure freedom after starting treatment, if their exam is normal, if their EEG is normal, if their MRI is normal, and if they have a childhood onset of seizures between 2 and 10. And specific epilepsy types can improve this prognosis. For instance, childhood absence epilepsy has a better prognosis than juvenile myoclonic epilepsy for seizure remission. But then the converse, why should we consider keeping patients on medication? So if the patient's seizures begin after age 16, if they've had breakthrough seizures after starting treatment, if their EEG has shown generalized epileptiform discharges in the past year, or if they have a clinical history of myoclonic seizures, focal seizures with impaired awareness, or tonic-clonic seizures. If they've been taking more than one anti-seizure medicine, or if there is a neurologic deficit on their exam. Those are reasons that you would want to hesitate from just taking away their medications and considering either a switch, but counseling the patient about risk. So now I want to discuss surgical therapy and cardiac risk. So we'll go through some discussion about all-cause mortality, vagus nerve stimulation, its effect on sleep, and then some neuromodulatory therapies as well. So I'm not focusing this talk on, resective epilepsy surgery, because that's a huge topic, but I think the audience here likely knows that treating epilepsy with resective surgery is the best way to achieve seizure freedom in appropriate patients. And this was a good analysis of pediatric patients and their 10-year survival. This is not just cardiac death, of course, but it can show you that resective surgery improves survival the best. So that cohort had a 98% survival, whereas the vagus nerve stimulator cohort was 93%, but medical therapy alone was 89%. There is a substantial, significant difference with a very low p-value for these changes. So just keep an idea of sort of the relative effects of these medical versus surgical therapies. The vagus nerve stimulator was first used in 1988, and it was FDA approved for focal epilepsy in 1997. I'm sure you know that this is a neurostimulator that targets the descending vagus nerve in the neck, and has a battery, and GNI implanted the first Aspire model that had recordings of heart rate along with the VNS. So the technology has improved over time to allow for some modulation based on heart rate. Unfortunately, we don't have an FDA approval for this therapy with generalized epilepsy, which cannot, in most cases, be treated with any surgical resection or at all. But we do have some data. It does show that genetic epilepsies that are not Lennox-Gastaut, so Lennox-Gastaut is considered to be due to sort of more acquired defects. We think that those patients do better. And the type of seizures that respond best to the vagus nerve stimulator are the generalized tonic-clonic seizures. So this is regarding seizure control for vagus nerve stimulator. So I think many epileptologists would sort of shy away from doing vagus nerve stimulator as first line if surgical resection or other targeted therapies are available. But I do want to bring to your attention that sort of data within the past 10 years has started to make us think a little differently about the potential for VNS improving and mitigating the cardiac risk of epilepsy. So this was a study in 2014, and they did ambulatory EKG monitoring before and after vagus nerve stimulation. And they looked at two features of the EKG. And one was the T-wave alternans. So here is a diagram showing you how from beat to beat, you can have a change in the amplitude of your T waves. And they showed sort of, I'll show you the graphs, but it's better that your T waves have a more consistent amplitude rather than varying. When it varies, that's associated with impending ventricular arrhythmias and increased risk of sudden cardiac arrest. And then they looked at heart rate variability. So we think that the autonomic nervous system contributes to heart rate variability. The parasympathetic nervous system and the sympathetic nervous system contribute to the low frequency power of heart rate variability, whereas the parasympathetic nervous system primarily is the contributor to the high frequency power. And then you can do a ratio of the low frequency to high frequency powers. And that's a rough measure of the sympathetic nervous system dominance, which, is considered to be not ideal for cardiac health. So these were the graphs before and after VNS. And you can see that for the heart rate variability, there was an important change for the better of the low frequency to high frequency ratio and the low frequency ratio. So there were like potential clinical improvements. Still, of course, because this was an epilepsy population, and we know that these patients can have this epileptic heart, these patients who went for VNS had abnormally high ratios to begin with. So that we should keep that in mind. And the effect on the T-wave alternans was significant in all the three, precordial electrodes that they analyzed. So VNS is not FDA approved to treat cardiac disease, but it's very interesting because there's actually a fair amount of literature about its use as off-label as a treatment for cardiac disease. And this is a diagram that can give us sort of an explanation as to why this happens. So this is called the inflammatory neural circuit. And inflammatory markers that are listed here in this bubble alter the peripheral inflammatory tone. So it's not just direct sort of electrical effects, it's also an inflammatory change. And nuclear factor KB is affected by this, which results in increased inflammatory signaling to the central nervous system via the brainstem. And then this in turn results in an output that generates an inflammatory signal again. And so this sort of cycle of inflammation and feedback can be altered by the vagus nerve stimulator. And that's why it can be beneficial in cardiac disease. So if it can be beneficial potentially in cardiac disease, then we think that it may mitigate the cardiac risk for patients over time. And there is data that the company Livanova, who makes VNS, can provide that does indicate a improved risk from SUDEP over time. I don't like to omit any potential negative consequences of any therapies. But it's not clear if the effect of the vagus nerve stimulator on sleep apnea is really clinically relevant. But this is perhaps in some cases, you may want to consider doing a sleep study before they get a VNS if you think they might be at risk of having sleep apnea. And you may want to be mindful that you may want to treat sleep apnea more aggressively after a vagus nerve stimulator. Because look here, this is a sleep study, and I don't read these for a living, but fortunately I have a sleep consultant that I was able to discuss this with. So this is a case in which they did the study while the patient was having VNS therapy on. And so the chin lead shows that there is the stimulator on. So this is sort of the artifact. And then the snore lead shows that it's not a chin artifact because of snoring. The patient stopped breathing here. Okay. So this is for, it's considered to be an apnea. And then afterwards, they had a desaturation of 3%. This particular study is consistent with sleep apnea. And they do find when they analyze most sleep studies of patients with VNS that they're not most, but I mean, a substantial proportion can have what we call sleep disordered breathing, which really isn't sleep apnea because there's not enough hypoxia. So I think the overall clinical effect is that, if you implant somebody with vagus nerve stimulator, they probably have an improved cardiac risk overall, despite effect on their OSA. And OSA is something that you can mitigate independently. So I haven't really seen that this particular problem is something that should make us stop implanting. However, for some cases, if you suspect that obstructive sleep apnea could be a risk, then it's something to monitor for. And of course, treating obstructive sleep apnea can also help improve epilepsy, which is something else. Going into the more targeted neuromodulation therapies. So, how do these therapies affect cardiac risk? So we do have some data for responsive neurostimulator or NeuroPace. They found that the SUDEP risk after 9 years was 2.8 out of 1,000. Now, going back to our initial slides where I discussed the risk in the pre-surgical populations of which these patients were already part of, that risk is much higher. So it seemed like this was a favorable SUDEP risk in this population. And what's interesting and helpful is that because the RNS records data from intracranial monitoring, that we actually have some practice. We have ways to inform our practice. So Davinsky published this. There were 5 patients with definite SUDEP, and only in about 3 of them was there a seizure proceeding. So it does confirm our thought that not all SUDEP is the, the aftermath of a seizure. Deep brain stimulation is now approved for epilepsy. Well, it's not yet approved, I'm sorry, for epilepsy by the FDA, but there's pending application. The Sante trial was the trial of the DBS of the anterior nucleus of the thalamus. Other targets include the central median nucleus and the hippocampus, but we have a lot more data on the anterior nucleus. And also with this population, the SUDEP risk was good, considering these were patients who would have a naturally high risk of SUDEP, so 2 out of 1,000. Newer DBS models who came out recently actually can record some data as well, so that's also going to be interesting and hopefully informative. So I hope I'm not running over at this point. I'll let Dr. Glebus tell me if he thinks I am, but I did want to try to.
We're good. We're good.
Okay, very good. So again, I had the 3 cases, and this is the opportunity for you to sort of read through them again. And I would hope that there would be some members of the audience who would want to participate and tell me their thoughts about these questions.
I'm not sure they can because they're all muted. So.
Oh, okay. Well, I don't know. I guess was there the way in the chat? I think I should have asked about this before. I'm sorry. So I guess I'll just go and give you my own thoughts.
Yes, please. So,
okay. All right. So just to review. Yeah, I thought about that later. I was like, did we go over that? So this is case 1. So this is a 41-year-old man, epilepsy since age 14, focal seizures with an aura. He's still having them, and he has a history of generalized tonic-clonic seizures. Okay. So he's got this history of generalized tonic-clonic seizures, but they're controlled, right? However, focal seizures that are still not well controlled might give him a higher risk of SUDEP than sort of the community population, because he's still having them. Now he's taking carbamazepine, which we know could raise his lipids and interfere with any statin therapy. So, understanding his history of hyperlipidemia, this is somebody that I would certainly check a lipid panel for, because many primary care physicians will not be screening patients of the age of 40. But since he's been on this medication, presumably for a number of years, then he would be at risk of accelerated atherosclerosis. So for this patient, you would definitely consider whether switching him from carbamazepine to another agent, such as lacosamide as a second therapy, could be beneficial for his overall cardiac risk. However, this patient continues to have refractory epilepsy. He has an epigastric aura. He seems to have a stereotype seizure. He may be, in fact, a very good candidate for epilepsy surgery. And that we know can definitely improve his risk of, future seizures and his risk of SUDEP. So this is a patient who I would not only work on monitoring him, consider medication changes that would mitigate his risk alone, but I would be moving him toward a surgical therapy too. Case number 2 was our 19-year-old woman. So she has a developmental encephalopathy. And so that alone gives her a higher risk of SUDEP. She also has nocturnal convulsive seizures. So we think that nocturnal seizures may worsen your risk of SUDEP. And she's still having them. So again, she's uncontrolled. When we did her EEG, she has generalized discharges, and we know that generalized epilepsy, in particular, some genetic epilepsies have a higher risk of SUDEP. So a patient like this may have transitioned to see me from the pediatric practice and may not have all her records with her. So of course, I would want to ask did this patient undergo any genetic panels? You know, that we don't, maybe not necessarily a Dravet patient, but certainly warrants, you know, some more workup if she hasn't had that. So I would definitely counsel this patient and her family about the risk of SUDEP. And I think that one of the main reasons to do that is that this can motivate the patient and family to be more aggressive about seizure control. I think that, you know, in light of the new warnings about lamotrigine, for this patient, I don't think that I would consider lamotrigine to be necessarily problematic cardiac wise, but if she were to have Dravet's, that might be different. So certainly I would consider, you know, increasing her dose of medicine first, adding a second agent or switching an agent. Most importantly, basically having seizure control. Understanding her other cardiac risk, if she has any other history, would be important too. So for her, since she has generalized epilepsy, you know, there's not a resective surgery that can be beneficial. But we do see that VNS can mitigate cardiac risk with time. So this would be something I would definitely want to present to this family as a potential alternative to medical therapy. Even some of the other neuromodulatory therapies have started to have some data with generalized epilepsy. So I would definitely escalate medical therapy for this patient, counsel to improve compliance and, you know, frequent visits, and then even really keep surgery as an option for this one. Case number 3 is our 50-year-old who said she had staring spells, but we don't have other information at this point. So, you know, was this absence epilepsy? Was this focal epilepsy without convulsions? So she's been on this medication for, you know, at least 20 years, and we don't even know when she started it. So we know that she already has been exposed to medications that can give her a long-term risk of atherosclerosis and independent of hyperlipidemia, just of cardiac risk in general. So this is somebody that you want to make sure you form a good relationship with. You know that she already has hypertension and hyperlipidemia, so we're thinking about her heart. So, you know, the first thing I do with patients like this is that I start ordering evaluations, after some initial counseling. So what are the levels of her phenytoin and carbamazepine? Are they very low? And perhaps they're not doing much anyway. You know, I would, you know, make sure that she has an updated lipid panel. And then I would start discussing getting some testing to understand her risk if we were to want to taper medications. Right. So she would be a good candidate for medication tapering. But in order to convince a patient like this, I think you have to, you know, have some good discussions and really get some data to help inform them. So an EEG that might actually show 3 Hertz spike and wave discharges, it can still happen in adults, or may not, or show focal spikes, you know, that, you know, would certainly affect your counseling of somebody if they still had epileptic discharges on their EEG. Even consider an MRI, you know, if perhaps there may have been some focal epilepsy. So, you know, this is how I really approach these patients, is that, you know, I continue to counsel them, but I also, you know, make sure that we can get data to do this. And sometimes the patients can be resistant even to getting data, and they really don't want to make changes. But, you know, the more data we have from population studies, the more we know that these patients can be at risk. So in summary of my talk, you know, SUDEP is unexpected death. It's not directly caused by a seizure necessarily, but related to chronic heart changes and by treatment, that can be caused by the treatment of epilepsy too. We know that anti-seizure medicines can be pro-arrhythmic, especially things like IV phenytoin, and enzyme-inducing anti-seizure medicines can affect lipids and other markers of vascular risk, and so can valproic acid, most likely. We know that carbamazepine can reduce the efficacy of statin therapy, and that you can't necessarily just mitigate that risk by treating their hyperlipidemia. And we know in population studies, enzyme-inducing seizure medicines are associated with greater cardiac risk independent of their hyperlipidemia. We talked about considering the risks and benefits of medication changes or discontinuation based on their epilepsy syndrome, their seizure types, their seizure control, and their comorbidities. And we did talk about how surgical therapy, including standard resection or neuromodulatory therapies, including vagus nerve, responsive neurostimulation, and DBS, can mitigate the cardiac risk for epilepsy patients. Finally, in the future, this is sort of my wish list for this topic. We would like to see more biomarkers that can help us predict SUDEP and cardiac morbidity in epilepsy. And this will be, I believe, a lot more genetic markers too. But we really want to get those biomarkers so that we can develop guidelines for how we go about doing cardiac monitoring for epilepsy patients in general. Should we be targeting certain groups for, Holter monitors and things like that? Believe it or not, it's been many years, but we still don't really have excellent cardiac monitoring guidelines when we give IV sodium channel blockers. And we do need to elucidate the effect of valproic acid on overall vascular risk. We definitely need more data, and this will be coming, of course, with the newer anti-seizure medicines like clobazam, brivaracetam, perampanel, cenobamate, especially because, some of these can have mixed effects on the cytochrome P450 enzyme system. And, we're looking forward to our ability to inform our practice with data that can be gathered from our neuromodulatory therapies like responsive neurostimulation and DBS. Okay, so that concludes my talk.
Dr. LoPinto, thank you very much for this really insightful and concise talk. I think I'm just going to squeeze in a couple questions. And one of the things, the SUDEP prevention, obviously, it's a big topic. And you mentioned about adenosine receptor blockers. And, the typical way of thinking, theophylline or similar medications, is there any movement to try to use these medications, or is just still in the theoretical research realm?
Right. So there really, I didn't see a great amount of really good literature using, caffeine basically, or caffeine, but there's actually some analogs that are being developed, and there's early testing. The name is something that I cannot pronounce off the top of my head because I didn't write it down, but I can get back to you with the name. But I have come across a certain compound that is an adenosine blocker, but I didn't include it in the talk for brevity's sake.
They seem like SSR. Also another, sort of, if you can call it low-hanging fruit, the SSRIs. Some questionable data for children. We don't have the data for adults, or in adults it just doesn't work.
Well, you know what? I mean, it's like this. It is such a messy thing to really tease out for adults. I think for in the epilepsy world, we use SSRIs to treat depression because we know that depression that's untreated will worsen seizure control for most of our patients. And, there are some theoretical, concerns about SSRIs in the general population. There's always anecdotally concerns in my patients who had a seizure right after starting an SSRI. But on the whole, if you choose a low risk SSRI, such as escitalopram or citalopram, or even one of the SNRIs for treatment of anxiety and depression in your epilepsy patients, you're safe. And I think that in turn will improve you know, compliance with regimens, overall quality of life, and can reduce SUDEP risk indirectly. Whether or not that's a direct based on the brainstem is something that really that's a great future direction.
2 year, the mark of seizure free to consider taking somebody off seizure medication. Is it based on some science, or like in dementia world, we call young onset, late onset dementia, age of 65 is the marker, but it's purely somebody just made up that, that's when people usually retire. That's when we call it. Is this 2 year, mark, okay, 2 year seizure free, maybe we can talk if everything else checks out about taking the medication off. Where is that 2 year coming from?
Yeah, so I've never really found a great scientific basis for it, but there are clinical guidelines out there, that one should consider it after 2 years. So I tend to tell my patients that it's pretty much standard of care, but there's not really a great reason to say it's 2 years. So, but this is where the clinical guidelines are. So I think that you would be correct in using 2 years, but when I counsel patients, I really try to tailor it more toward, how severe was their epilepsy before, and what are their other risk factors. So, like I said, in my practice, I tend to go a little bit longer than 2 years. But I think it's also the level of comfort with risk that the patient has as well.
And the last question, what is your approach when you inherit a patient on multiple anti-epileptic medications, 3 or more, and the history or a quality of workup is unclear? Where do you start with it?
Yeah, so I mean, that's sort of like, it's sort of my day-to-day bread and butter. I mean, I get a lot of patients who, for instance, they are, in facilities, and, the level of workup is gone, after so many years. But this is actually a patient population I enjoy, for the reason that this is an interest of mine intellectually too. So you have to think about the interactions of each medication. I mean, I always sort of start with, just the workup. What are their medication levels? Like, can we get an EEG? Not always possible with our intellectually disabled patients. So, I think I tend to really look at the overall picture, their age. I mean, there's a certain age at which you think that they probably have a much to benefit from switching medications. But, in patients who are more on the elderly side, like now they're 70 and upwards, I mean, what would your benefit be if you would actually have them have breakthrough seizures? So, a patient like the case I had, at age 50, and she's on 2 medications that we know can confer risk. You want to be pretty aggressive in, really counseling this patient, getting your data, and really building a case over time of switching. And I have been successful in convincing patients to do this. But it's, the approach means that you really have to, get them in for more frequent follow-up visits. And sometimes the patients can resist that. For patients who are like facility patients, I think at first I was more aggressive with just switching. But then I started to, really take a step back also and just look at the whole context a little bit more, like what is the potential benefit, for these patients. And, unfortunately, when it comes to some of these more, advanced therapies, like the neuromodulation and things, that's a hard one to really get patients who are in this facility care on board with, because the families kind of, they may not have much involvement. And so the persons who are making the medical decisions, may be risk averse, may not want to have sort of the hassle of having a patient with a device, but that can definitely improve the care for these patients.
Dr. LoPinto, thank you very much. It was a great talk, and many people feel that they really benefited from this talk. So thank you again for joining us. Have a good day, everybody.
Thanks, everybody.